Dr. Lydia Conlay. She's the Russell D. Shelden and Mary B. Shelden Professor of Anesthesiology and Vice Chair of the Department of Anesthesiology at the University of Missouri. She started her medical career with MD at LSU, did OBGYN internship at Hopkins, and went on to do an anesthesia residency at Mass General Harvard. Please do not hold that against her. Went on to earn a PhD in neural and endocrine regulation at MIT and an MBA at Boston University School of Management. She spent 20 years at Harvard MGH, where she was the director of ambulatory anesthesia and became a national leader in ambulatory anesthesiology. Moved to Temple University as the chair of the department, and then to Baylor as chair and the physician-in-chief of anesthesiology at Ben Taub. And she is a past president of the Society for Academic Anesthesia Chairs and Society for Ambulatory Anesthesia. And she was awarded the International Anesthesia Research Society's annual teaching award in 2009. This is a very big award. And I also, there are many other awards there that I'll let you read on your own. And I also want to mention that she's currently the vice president of the Missouri Society of Anesthesiologists, a group very close to my heart.
Thank you so much. And can everybody hear me in the back? That's usually not a problem. I really want to tell you what an honor it is to have been asked to speak to this group. I think that alums of an institution are among the most valuable, and certainly for me to be asked to speak here is great. It's also an honor to be speaking with you, Dr. Churchill. The dean that I first worked for at Temple was a radiologist. And so when Joe Viets told me that the dean was a radiologist, that was a great incentive for me as well. I'd also like to thank Steve Smith, who's been essentially a one-man welcoming committee for anesthesia here. Showed up in our office when we'd only been here a couple of weeks one day to say hi, and has turned out to be an incredibly welcoming and generous friend, and has been very helpful to me personally and anesthesia in specific. I'm going to talk to you today about postoperative cognitive function, and in particular postoperative cognitive dysfunction. You may have heard the saying, I saw a surgeon come in the back, you may have heard the saying that anesthesiologists are the doctors who take care of patients while surgeons do things that would otherwise kill them. Well, I am fond of saying that going to sleep is free. Anybody can put you to sleep. It's waking you up like you were before that you pay for. And but increasingly, that is becoming tricky these days. I'm going to talk today about the general topic, are anesthetics poisons? Are they bad for the brain? I'm going to cover postoperative cognitive function, postoperative cognitive dysfunction, the role of the processed EEG, which we do in many of our operating rooms these days. And then I'll weave back in to talk about this concept of anesthetics and neurotoxicity. I'll talk a little bit about the preclinical or animal data. I'll talk a little bit about data from the pediatric population today. And as a native Louisianian, I'll add a little lagniappe or a little something extra at the end of the talk. Those of you from Louisiana will know that lagniappe can be the icing on the cake, or it can be what you use to fertilize your roses. I hope you'll think it's more of the former than the latter. But at any rate, for postoperative cognitive dysfunction, the definition is a deterioration in intellectual function that presents as an impaired memory or concentration. It has to last several weeks. It can last several weeks, or it can be permanent. The diagnosis is only warranted if it is corroborated with neuropsychological testing, and if the evidence of memory loss is greater than one would normally expect with aging. And this is a schematic of postoperative cognitive function by psychometric tests. Normal patients are impaired on the day of surgery. But however, by a week, we're getting back to normal, and certainly by 90 days, our cognitive function is back to normal. But in a significant population of patients, they just are not the same after a surgical procedure. And on day 7, they're recovering a little bit, but at 90 days, there is a significant difference from baseline. Studying, I'm going to call it POCD, and that's really the only abbreviation I'm going to use here because it's a bit of a mouthful. There is a lack of consensus regarding the formal diagnostic criteria. There's also a lot of noise in the system because the postoperative changes can be subtle or they can be severe. Preoperative cognitive function can vary significantly among patients. It's expensive to follow up with the battery of 10 psychometric tests, and there's a long course. And in fact, the DSM-4 defines cognitive functions by definition as of being 3 months or longer in duration. Now, there was a lot of attention given to POCD in the media maybe 10, 15 years ago, and it was about the same time that there was a lot of interest in on-pump coronary artery bypass grafts or CABGs and off-pump CABGs. And so the cardiac anesthesiologists really became the group to define what is POCD, how do we look at it, how do we study it. This is just an article that was in the New York Times about this time. Saving the heart can sometimes mean losing the memory. And the concept was just going on the cardiopulmonary bypass machine was associated with a higher incidence of cognitive dysfunction. We now know that that's not true, and I'll come back to some of those data in a little while. But the first study of postoperative cognitive dysfunction was done by Dr. Bedford in 1955 and published in The Lancet. He looked at 1,200 patients and defined older as 50 years old of older. That's a problem for me. He looked at patients who had operations under general anesthesia, and he found mental deterioration in 10% of patients. He made conclusions, most of which without data, that cognitive decline was related to anesthetic agents and or hypotension, and said that operations on elderly people should be confined to the unequivocally necessary cases. I did not give you a major disclaimer, and I should. By definition, if I'm going to look at animal data, pediatric data, postoperative cognitive dysfunctional data, obviously in 40 minutes I'm going to be hitting the high points of each. This is very much a talk from 30,000 feet, and certainly on several topics that could easily warrant an hour of grand rounds each. So, but I think it's no news to anybody that the population is aging. And so disorders that affect disproportionately elderly people, whether you define it as age 50 or age 60, are increasingly becoming of interest. So let's fast forward to the late 90s, the first long-term multidisciplinary center study looking at cognitive dysfunction in a large multi-center study. There were 8 European countries in the United States, 13 hospitals. Research was conducted over 2 years. Excuse me. And they found that the incidence of postoperative cognitive dysfunction was much larger in patients who had had surgery than in patients who had not. And it persisted in a significant number of patients as well. They found that anesthesia and surgery were associated with postoperative cognitive dysfunction. POCD was not, however, related to the occurrence of hypoxia or hypotension. That's an important finding. But they found a lot of variations in the findings from different centers. So much so that they asked, well, gee, could we generalize the findings from this large multi-center study to any individual institution? They didn't know that if these differences were institutional practices or perhaps genetic populations that tend to be cared for in individual institutions. But nevertheless, that was one of the findings of the study. It was followed from the University of Florida about a decade ago of a study in 1,200 patients undergoing elective surgery, and I'm going to go through the paradigms fairly closely because they use the same paradigm as this large multi-center study, except here they defined elderly as 60 years and older. That bothers me too, by the way. And they used as controls primary family members of the patients who had undergone surgery. They used the same psychometric test battery of 10 psychometric tests, and as outcomes they looked at 2 endpoints: POCD, postoperative cognitive dysfunction, and mortality. And I'll show you the results for each. But first, I think it's important to look at the inclusion and exclusionary criteria. Inclusion, patients 18 or older, anesthesia for 2 hours, major surgery, and good mental status function prior to the surgery. Exclusion criteria, and I think these are very important. They excluded patients with known cardiac or neurosurgical disease, alcoholism or drug dependence, major depression, and patients not expected to live 3 months or longer. So it was a fairly rigorous study. For the baseline characteristics of the patients, the only difference was that the older patients had a higher incidence of comorbidities. One would anticipate that. But their baseline educational function and baseline mental status function was about the same. They found that there was an increase in the incidence of postoperative cognitive dysfunction in all groups at hospital discharge, but it persisted in elderly patients in particular. They found that POCD was more common in elderly patients and those with lower educational achievements, and those were the two large conclusions of this study. Now, as for the other endpoint, mortality, they found that in patients with cognitive decline, mortality was higher at discharge, and it was some 4-fold higher than controls 3 months after discharge. And I'll come back to that a little bit in the lanyap, which looks at EEG function or spectral EEG and mortality. They found that mortality was increased by concurrent comorbidity. That's no surprise to anyone. But they also found that anesthetic management had a significant effect. In particular, the use of volatile anesthetic agents, which are the vapors that we use all the time in most of our cases. Systolic hypotension was also important. And the cumulative deep anesthesia time, the time that a patient is deeply asleep versus light anesthesia time. And this they defined as a bispectral index number of less than 45. Now let me introduce you, if you're not aware of it, of this concept of the bispectral index. You may have seen it in Time magazine. This was originally the, quote, light anesthesia monitor. And that's the reason that these things were sold originally and marketed. It is a processed EEG, similar to a Holter monitor, which processes an ECG. The algorithm is intellectual property, so it's a magic box, and it gives a magic number. The number, awake is 100, brain dead is 0. The idea is that a number of 70 or above for 15 minutes is associated with awareness. Some people would now say this number should be 60 and above is associated with memory and awareness. And the newer concept is that the lower number, i.e. the deeper anesthetic, may be associated with postoperative cognitive dysfunction. You will hear me talk about the BIS number, and we're talking about the processed EEG. This association between deep anesthesia and postoperative cognitive dysfunction has been confirmed now by several studies. The most recent, a randomized controlled trial of almost 1,000 patients. Patients were randomized to the BIS-guided care, where the anesthesiologist saw the BIS number and the BIS monitor, or the routine BIS-blinded care. BIS-blinded care, they measured the number, but the anesthesiologist didn't get to see it. The BIS was lower, i.e. the anesthesia was deeper in the group of anesthesiologists that did not see the BIS number. The BIS number was higher, the amount of anesthetic that was administered was higher in this group that had deeper anesthesia. That follows, more anesthesia, deeper anesthesia. Postoperative cognitive dysfunction was also higher. The incidence was also statistically higher in this group who had more anesthesia and a deeper BIS number. I just came back from the American Society of Anesthesiologists meeting. It's 20,000 docs last week. This was an abstract that was submitted and judged to be the best abstract in the meeting. And it looked at patients who had cardiac surgery versus controls who were family members versus post-cardiac surgery using functional MRI scanning. And they looked at two types of brain function. One was the working memory network, and found that the function of the working memory network was lower in patients who had had cardiac surgery than in pre-surgery or in controls. And they similarly found that the default mode network which is something that they equated to resting brain function, was less in patients who had had cardiac surgery than in pre-surgery and in controls. And these changes were associated with postoperative cognitive dysfunction. However, nothing is simple when you study humans in parameters like this. This is a study that came out last year from Perth, Australia, where they looked at the incidence of postoperative cognitive dysfunction, and now this is again using the battery of 10 psychometric tests in patients who underwent major surgery. Hip replacement is one of the operations that's been particularly implicated with POCD, and of course coronary artery bypass grafting. But he also looked at patients undergoing coronary angiography. And this is important because these patients didn't get general anesthesia. They got sedation. And at 3 months after the procedure, the incidence of postoperative cognitive dysfunction did not differ between the three groups. So what does this mean? The current thinking is postoperative cognitive dysfunction is a symptom complex that first involves patient predisposition, i.e. genetic factors, but it's affected by aging, it's affected by the presence of anesthesia, and it's also affected by stress. And we know in animals and in many human studies, stress is not good for cognitive function, and having anesthesia actually alleviates stress, and that's a good thing. But put these three together, and we tend to have the syndrome of postoperative cognitive dysfunction. This weaves for me into the topic of, so are anesthetics poisons? Are they bad for the brain? And I'm going to show you a few of the preclinical or animal data. There are probably 40 of these now, 45 of these. The first paper was published in Science in 2003 and showed apoptosis in the hippocampus and an impairment of hippocampal long-term potentiation. It was followed very quickly by an article in the Journal of Neurosciences showing that the pups that were exposed to isoflurane and midazolam and nitrous for 6 hours also had impairment of the spatial reference memory, and this persisted into adulthood. I have combined two studies in this slide for the sake of simplicity. Rhesus monkeys, fetuses, and newborns exposed to ketamine for 24 hours, either prenatally or beginning at 10 months of age. Compared to controls, the controls outperformed the ketamine counterparts in accuracy and the speed for task learning, in color and position discrimination tests, and the change persisted for at least 10 months. We've also found issues in children. A large population-based retrospective age-matched birth cohort study, that's a mouthful, showed that exposure to 2 or more anesthetics before age 4 doubled the risk of learning disabilities. There are 2 or 3 other studies like this. A study from the New York medical system showed that children undergoing hernia repair before 3 years of age were twice as likely to carry the diagnosis of a developmental or behavioral disorder. Similarly, twins receiving anesthesia performed significantly worse than their siblings on educational tests, but of course, again, in humans, none of the data are perfect. So there is a study that shows that twins discordant for anesthesia exposure showed no difference in educational outcomes. And there was no difference at 15 or 16 years of age in patients who had an inguinal hernia repair versus their age-matched control populations. Well, these studies, and there are probably 5 or 6 of them, provoked a commentary in the New England Journal of Medicine last year, followed by an editorial addressing the possible neurotoxic and neurodevelopmental, in particular, effects of anesthetics on children. This led to the FDA to consider the potential risks of anesthetics in children, and their findings were published in the JAMA last year, which basically suggested that the data are imperfect, but at this point that anesthetics should not be administered to children unless it was absolutely necessary. Like we all go out and anesthetize children for fun anyway. But anyway, this is a very serious proposition, obviously, and it lends credence to the potential concept that anesthetics are problematic, particularly at extremes of age. The philosophy is that as children are growing, their brains are developing, they have less developmental or buffering capacity, and development is impaired. In the elderly, there is less buffering capacity. Hence, negative changes are seen because there is less buffering capacity. So now for a little lagniappe, a little something extra. Remember, I showed you this study from Monk and colleagues showing that mortality was about 4-fold higher 3 months after surgery in patients with postoperative cognitive dysfunction. The question is there an association between the processed EEG value and mortality? And it's not rocket science to see that it's easier to go into a large database and look at numbers of survival than it is to study a cohort of patients that are receiving 10 psychometric tests every so often to look at cognitive function. So this has been a very active area of study. And this was a study also by Terry Monk who looked at the percentage of time that the BIS monitor was used within an institution and showed a rank-ordered reduction of mortality as BIS was used in an institution. Now, obviously, these changes are very small, but it is very interesting that they are quite tight with respect to a rank order. Similarly, Moretti and colleagues looked in 20,000 adults from the National Tumor Registry, the National Death Index, and the Social Security Death Index. And they looked at a variety of different factors to see what might predict mortality. And in that study, they found that the higher the proportion of the case that was monitored for neurological function by BIS, and the higher the median BIS value, i.e. the more awake the patient was or the less anesthetic they were receiving, the lower was the risk of mortality. Now, that's an interesting finding. But when you look in people and you see a slide like this that shows that excuse me, the higher the BIS value, the lower the mortality, and it follows right up. That's quite an amazing slide to my thinking. I've rarely seen things that tight in humans. There are now 4 positive studies linking a low BIS to mortality, 1 positive abstract and 1 negative study. And in this negative study, they did not do the battery of 10 psychometric tests. They only did 3, and the study was accompanied by a rather terse editorial linking the low BIS and mortality. Lindholm and colleagues tried to say, okay, well, how much of a factor is it? Is it as important as a pre-existing malignancy? And no, a low BIS is not as important in terms of determining mortality as is the comorbidity, pre-existing malignancy, or age, but it is in the top 6 factors predicting morbidity. So what is the current thinking as terms of how these things are related? Well, first, if there is no processed EEG or BIS monitor, it is possible that that patient gets a relative anesthetic overdose, i.e. more anesthetic than they need, which leads to a BIS value, which leads to a poor outcome. It's also possible that excess anesthesia can lead to poor organ perfusion, which in and of itself leads to a low anesthetic value and poor outcome. Or perhaps organ dysfunction can by itself greatly reduce the anesthetic requirements, which is something that Steve and I see every day, lead to a low index factor and poor outcome. So where are we? Are anesthetics poisons? And the bottom line is there's a little fire and a lot of smoke, and we don't really know yet. What we know is that anesthesia is probably good, but anesthetics are probably not. So why not provide anesthesia with a minimum of anesthetic if it's possible? And so while we wait, and that was actually the topic of an editorial in the recent Journal of Pediatric Anesthesia, it seems prudent to avoid hypoxia, hypotension, and unnecessarily deep anesthesia. Thank you so much. It's a pleasure to speak with you.
Well, thank you, Dr. Conlay. I don't know if we have any questions out there. We can pass this microphone around and so we can all hear.
Thank you. That one of the first slides you showed that showed the takes about 3 months for us all to get back to normal, or most of us to get back to normal after any kind of surgery. What's the significance of that cognitive dysfunction? So at 2 weeks, and like when people are going back to work, when they're going back to driving, when they're going back to life.
I think
you can measure it, but
that's a great
clinically
question.
Or in life.
And another question for me that is perhaps even more important is, should someone who's had a minor surgical procedure drive himself home? Which I did a few days ago. But so, I mean, your question is a great one, and I think we don't know the answer to that question. I think simply showing that it does take time to recover, and that procedures, albeit stress, be it a change in our routine, be it patient predisposition, are not innocuous. I think this is really all we know on that topic.
Yeah, and just with the focus on, and you can have this robotically, and maybe your surgery takes 2 hours longer, but maybe you could go back to work in 2 weeks. Well, maybe you shouldn't.
Okay, well, you just touched on another thing, because robots don't change outcomes. But they're great marketing tools, and everybody's got to have one, and if they've got 2, well, you've got to have 3. So, any other questions? Yes, sir.
Is there an association with POCD and the way that, like, post-concussive syndrome, and talking about getting back to work, we see young athletes that have their appendix out, that laparoscopic, and then heal quickly, and they want to get back to the football field?
Oh boy, is that a great question. I have a young friend who's a state-ranked wrestler who 2 weeks ago had a concussion on the football field. And he's had no headaches now for a week, and so he wants to start wrestling again. And bottom line is, we don't know. Most of these studies on postoperative cognitive dysfunction have tried to ferret out individuals who have other types of CNS pathology, because there's so much noise in the system anyway. They've tried not to study patients that may have other pathology that cloud the results. So the bottom answer to your question is, I don't know the answer. I don't think the answer is known, but it's a really good question. I don't think much of the public has been aware of the concept of postoperative cognitive dysfunction, although many of us anecdotally may know relatives who were just not quite the same after they had surgery, and physically they seem fine, but they sit in front of the window and stare out of the window. Yes, sir.
If you look at animal studies and you do the cognitive or task learning tests in the young or the developing brain, is it really fair to compare that to what you see in the adult model? Should you not be doing those studies in adult animals and then comparing that group to adult humans rather than? See what I'm saying?
Yes, and I did not show the developmental studies that are associated with postoperative cognitive dysfunction. I didn't show that group of studies. I only showed the pediatric side. There are studies that look at dementia and, for example, Alzheimer's knockout mice, compared to relative mice. I just didn't have the time to go through everything. And I started this as with an interest in postoperative cognitive dysfunction. So I just didn't show that, but I will tell you that the preclinical data in aging animals are not as compelling as the preclinical data showing the problems of anesthetics with neurodegeneration, or not neurodegeneration, I'm sorry, neurogenesis. The animal data, neurodevelopment, thank you, I'm sorry. The animal data on the neurodevelopmental side are tighter than the animal data on the dementia side, which is another reason I didn't show it. It's been studied, it's not as tight. Yes?
Obviously, the effects of postoperative pain and pain management is huge. And did they try to balance that out to figure out how much of it was actually the postoperative medications and pain as compared to just the anesthesia?
Well, I think that's a great question too. And I think that by going 90 days after the surgery, with the fairly strict exclusion criteria, I think the probability that somebody would still be having pain from surgery at 90 days is certainly present, but is not as high as it would have been, say, 7 days after. Your point's very well taken. We know that pain affects cognitive function without medicine, and we know that pain medicine affects cognitive function, but I simply have not seen the studies done with respect to POCD and the scenario you mentioned. Yes?
Two questions. First, any genetic basis for metabolites? And number two, were you to have to go to sleep tomorrow, what would your choice for anesthetic?
Oh, well, I went to sleep 3 weeks ago, so I can tell you, but his choice will be different than my choice. Maybe not, I don't know. Let me answer that for Michael Jackson drug. Love it, want it, happy with it, good drug, good on the brain. Afterwards, you are, if anything, a little high. I went home, I cleaned the house, I cooked steaks, I did all of this, and then I crashed. I think it's great. Propofol is a fabulous drug. Would that be your choice?
Yeah, I think multi-component, but yeah, propofol.
But he said multi-component, which means many things, and a lot of it also depends on the case and the patient and that sort of thing. Now, the first question you asked me, genetics. We think so. We don't know so, but we think that patient predisposition is a significant factor. We think so because patients that have coronary angiography have POCD problems. We think so because in this multi-center study in Europe and the United States, the many of the factors were so different institution to institution. But so that we think so, but we can't really go any further than that. Yes, sir.
I had more of a comment than a
Yes.
question. Back to the concussion. What we now know is that concussions are occurring in many segments of society, not just in athletes.
Yes.
Auto accidents, but people fall at home, hit their head, but never see the doctor. Then they come in a few days later with symptoms, and all groups agree that it's the second impact that probably is more crucial than the initial. If you give the brain enough time to heal, then the second becomes less of a factor, but that's kind of the key element. So the question he posed over there was the time for the brain recovery is individually determined, and so we have some testing to do that with, but it's still not scientifically defined that well yet. So that was just a comment more than anything. It's the second time you get hit that's crucial.
Thank you. The gentleman in front had a question.
Have you looked at, we're looking at drug reactions now and the differences racially in that, fast acetylators and things like this. Is this an area that it would seem like it would be fairly likely to give you some insight into the response?
I totally agree with that. I think that, a lot of the data that I showed you are still in abstract form, so this is pretty new stuff, and certainly that's field for study. Yes?
Lydia, is this the standard of care now?
It is an extremely political comment, and inside baseball, I wrote this talk because Scott Lutovsky gave me trouble putting it on in the cases, and I gave it to the neurosurgeons. Half of us think it is, half of us think it isn't, because half of the American Society of Anesthesiologists vehemently does not think that it is not a standard. Now, interestingly enough, pulse oximetry, there are no data to support the changes in pulse oximetry and outcomes. So this is a very contentious political issue, and it is not, for that reason, a standard of care. Yes, sir.
It's not surprising to me about the cath lab, the angioplasty, because as I pointed out, I think when anesthesia involved, we tend to use a little less. When one of my colleagues had a colonoscopy, he thought it was interesting. He said, "Oh, so how much did you give me?" And they said, "Oh, we gave you 8 milligrams of Versed." He was like floored, because generally we would do 1 or 2 titrate and everything. So to see something with a study like that where you had a higher rank with just what's considered MAC or sedation would not be too surprising at times. when anesthesia is not followed.
Well, it is surprising if you're going to say that it's due to general anesthesia, but yet patients who had a big procedure without general anesthesia had it as well. So I think the point is it's a multifactorial complex. 8 milligrams for cardiologists is not a lot to me.
Well, in anesthesia, it actually is we alluded to it a bit, there's a tremendous variation in the type of anesthesia. We've got potent volatile agents, we'd call them smelly gas anesthesia, and versus TIVA, total IV anesthesia. And even with TIVA, you've got propofol and then narcotics and then muscle relaxants and other medications mixed in there. Most of us would give what Dr. Cowan was the founding chair of anesthesia here, what we do today is called, he would call garbage anesthesia. He said, if you're going to use nitrous narcotics, use pure nitrous narcotics, don't touch the vaporizer. And if you're going to give a volatile inhalational agent, don't give any narcotic, don't give this or that. So that's kind of fallen out of favor today. But
No, not really.
Oh, you give it pure?
Well, I don't know. As you can tell, there are different styles, I think. Oh, you mean the concept of being pure?
Right, right.
Oh, purity is gone.
Yeah.
Everything's garbage. So
and so the difficulty then of determining what cognitive dysfunction versus general anesthesia. I mean, the general anesthesia could be many, many different drugs.
Yes, exactly, and many different things. I'm sorry, one more question.
Well, gastroenterologists have for years tried to get the procedure out of the operating room and then out of the hospital and into some quiet, pleasant outpatient setting. And then as the propofol has come in and the anesthesists are now coming to our places to help us put people to sleep, and that's such a relief, you know, to have someone else take care of that problem. So where should we be going with the kind of procedures that we want people to have every 5 years or every 10 years, no matter who they are or what, with the sedation aspect? There are studies that show people trying to do it without sedation, and some don't tolerate that so well. Others showing that the sedation should be there and just done by a nurse or someone who's learned to do a propofol. Where should we be going with the screening procedures?
Oh, boy. I'm not biased on that point or anything, you know. Many of the gastroenterologists and other proceduralists, particularly in the outpatient and office-based setting, like having us around because their flow of their day, they can do 20 procedures instead of 10 procedures. Having said that, they can do 20 procedures in patients that can pay for it themselves, because we're having real challenges getting reimbursed in some of the settings. That is currently still very lucrative for anesthesiologists if they're in a private paying situation. But increasingly, these types of procedures don't pay. And I'm running over in time, but you're drifting into the political realm big time. Also because the gastroenterologist fee has a bundled fee, has a part of its fee for sedation. So that's been an issue in some of the carriers.